right, so now we're moving on to a topic that is heavily CK. Like, this is straight up clinical knowledge. Do you know it? Do you not know it? Have you ever even heard of it? Um, Almost none of this was even remotely mentioned on step one. You get some questions on step one about car accidents or like of course shock we've done. I'm not entirely sure why they have shock as a chapter here, as a section in this chapter, but we've already done shock when we looked at it in cardiovascular. We broke it down completely. We've talked about appendicitis, of course, even in step one. Vitamin deficiencies are a step one topic. But other than that, the bulk of this chapter is right here in these first 4 pages from 534 to 538. They basically summarize everything you need to do for patients that come in with all kinds of weird trauma. And it is pretty weird. If you've done your emergency medicine rotation, you'll see people coming in with injuries or traumatic events that you would have probably never really imagined would occur. And it's often like, oh shit, wow, how did you manage to do that? And you see it, and then you got to figure out immediately what are the things you need to look out for, what are the things you care about, what are you going to be managing. One of the things we definitely care about are the ABCDs, right? So we're going to see some of those things right now. Nurses are heavily trained on this stuff very well because they're the ones actually directly managing many of these patients. And the majority of this is going to be about making sure for us to know what testing we have to send out to check for any occult bleeding, right? Because a patient can have a really bad traumatic incident, feel fine within a few hours, right? But then turns out that either their spleen broke and they didn't notice, their pituitary broke and they didn't notice, or somewhere retroperitoneally they're bleeding out and they can't really tell until too much blood comes out, and then they go into shock, which is why shock is in this section. But this section is really just involved with hemorrhagic shock, if anything, and hypovolemic shock. Shock, as a grand scheme of things, has many other things like septic shock and cardiogenic shock, so neurogenic shock, and we've looked at all of that in good depth. We'll revisit that as well when we get to the shock section. Always good to revisit things. First thing we see here, trauma management. The Advanced Trauma Life Support (ATLS) algorithm divides management into 2 phases. The primary survey focuses on resuscitation and gross identification of injuries, while the secondary survey serves as a more detailed head-to-toe assessment of the patient, right? So when you get questions on this topic, you want to always make sure you think of it like this too, right? You got a trauma patient, primary survey, how is that looking? Secondary survey, what do we do now? So primary survey, first things first, airway, right? That's the A. Assessment, if the patient can speak clearly, the airway is most likely intact. If they can't, they could be choking on blood or some kind of trauma to the trachea, esophagus, something impeding their laryngeal area, and you need to check for that, right? So if they can't, consider these indications for emergency airway management. Structural airway damage. Consider structural airway damage. Maybe they have subcutaneous emphysema in the neck, gurgling noises during breathing, or major facial trauma with blood in the airway, right? So that's something you have to watch out for. Airway compression, possibly by an expanding neck hematoma. Somnolence, based off of the Glasgow Coma Scale, we'll look at that. Thermal or inhalation injury, suspect in patients with singed facial hair, facial burns, or soot in the posterior oropharynx or sputum, maybe because they were in a fire emergency, right? Management, make an airway. If they can't breathe, they're going to die. You want to make sure this is the first thing you check for. Are they able to breathe? Right now, a lot of times patients can't speak because they're actually kind of comatose, right? So that's different. That's not what we're talking about when we say they can't speak clearly. This is if they can try speaking, but they're coming off as they're choking or something. So one option is the endotracheal intubation. Intubation is the number one thing we usually go with, right? Preferred method, even in setting of cervical spinal trauma, which is something you have to watch out for. There's a trick question. We have it here in the book where a patient has a car accident. They're given a cervical brace because it seems like they have cervical trauma. No imaging has been done yet because you always have to stabilize patients before you can do CT, MRI. So don't pick these answer choices until you first pick the answer choice of stabilizing the patient. Very critical thing to watch out for. We're going to see that. You know, when you do these questions without having studied this first, you'll learn that you're very quick on picking, oh yeah, we should do an MRI of the spine or do a CT of the cervical area. You know, these are quick things that come to your mind because you could tell what's wrong with the patient. And sure, you're probably not wrong. It's just that it's not the next best step. The next best step and the first best step is to first stabilize the patient, right? To do a CT or to do an MRI, you have to send them away from the trauma bay, and they're no longer going to be monitored, right? So if they're unstable, you can't pick those answer choices. So endotracheal intubation, no matter what the case scenario is, will help at least get them breathing. Nasotracheal intubation with fiber optic bronchoscope, preferred if tracheobronchial tree is ruptured, right? If the tracheobronchial tree, maybe they have really bad chest trauma, then you have to do the nasotracheal intubation. Contraindicated if there's a basilar skull fracture, because you can possibly do intracranial penetration through this, right? If there's a basilar skull fracture, then when you're inserting something through the nose, the first time you insert something through the nose, it's pointing upwards. It's going towards the brain, right? So if there's a basilar skull fracture, the skull fracture might have opened up and you might insert it directly all the way to the brain and then cause brain injury, right? So you don't want to do that. So you check for these things. If the tracheobronchial tree is ruptured, then you do a nasotracheal intubation, but you don't do the nasotracheal intubation if you're going to send that tube all the way to the brain by mistake. These are the answer choices you don't really pick: emergency cricothyroidotomy and emergency tracheostomy. The cricothyroidotomy attempt only if other methods are ineffective, and that's very rare. It's almost never going to happen, and it's also not easy to do, right? You already have a patient who's probably not that well off and injured and all that, and then you're going to try cutting up their throat. That's not exactly the preferred method of handling things, but you know, if you have to, you have to. So if nothing else is working, this is what you have to do. Emergency tracheostomy, in general, never do this. Like, even the book is telling you this, right? And we've never actually, you know, you've probably never done a question, and if you haven't done URO CK questions, then when you do it, you'll see AMBO CK questions, whatever CK questions. When you do it, you'll probably never see a question where this was the answer, right? And if it comes to a point where it looks like you really need to do this, then you probably just better off doing the cricothyroidotomy. So the two case scenarios look like this. All right, so you have, well, this is your in the top here you have your tracheostomy tube, placed in between the second and third tracheal rings, right? This is very rarely ever the thing you do, and I think it's pretty safe to say you never do this. You know, the only time you actually do this is after the patient is completely taken care of, everything's good, and then sometimes patients have to go home with this setup, and you've probably seen it on some TV show or something. You know, patients go home with this device in there because their trauma was so bad that you can't depend on them to breathe from their mouth or nose, right? So then you put this tube in, and you can see it's kind of not entirely perfectly clear, but basically air is going to go in from here, and this is how they're breathing. When they try talking, it's a little hard for them, but they can. It's just not going to be that good, because remember, to talk, air needs to travel this way, right, through the laryngeal apparatus that we have. So it becomes really difficult to imagine doing this for a patient who you just got in the emergency trauma bay. They can't talk now, right? So you don't want that. Then it becomes difficult to tell the condition the patient is in. But this might be an answer choice for something you have to do for a patient who's going home. You've taken care of everything, they're done. Now you need to do this for them and then send them home like that because of the severity of the trauma in this area, right? And that'll be a clinical judgment you'll have to make. This here is showing you the cricothyrotomy. Right? So you just open it up, open the throat up, open this cricothyroid membrane up, and then they're good to go. So it says here, stabilize the larynx with non-dominant hand, and then cut off the thyroid membrane with that's a 1/2 inch horizontal incision, right? 1/2 inch. That's it. So this kind of information you always want to look up because CK loves having technical answer choices, right? This is actual clinical knowledge, and now you know how to do it to some extent. Now you just need the residency training of actually doing it. But you know, this is the amount of book knowledge you want to have, and that's as much as you can possibly do before you actually go take your test, right? Here on the left, we're seeing a question of a case scenario that is as strange as I was mentioning, right? So I said that in the emergency trauma unit, you would see cases that are really far-fetched sometimes, and you're just really going to wonder how someone was able to do something like that. So here we have a 5-year-old boy brought to the emergency department due to right-sided hemiplegia. His parents say that he has been having increasing difficulty moving his right arm and leg over the past 3 hours. This morning, about 10 hours ago, he tripped on a toy while brushing his teeth and fell forward with the toothbrush in his mouth, like that. And one of the strangest things, like it's actually not the strangest of things, but it's definitely strange. Like, especially to me, I can't remember ever really moving anywhere away from the sink while brushing my teeth. Even as a 5-year-old, I don't think I ever did that. He cried, but his parents did not know any oral bleeding. The boy did say, "My throat hurts," throughout the day, but was able to eat his lunch, which tells you that the esophagus is okay. And he's able to talk, so his trachea is okay. So these are some things you want to evaluate in your mind as you're reading these questions. The child has a history of ADHD, for which he takes methylphenidate. So this sentence is completely irrelevant. Right? It's an extra sentence called a burnout sentence. Right? They're just trying to burn you out. His mom has a history of migraines, and his grandpa had a stroke at age 62. Another burnout sentence, completely irrelevant to the case scenario here. Neurologic exam shows right hemiplegia, right hemianesthesia, and mild motor aphasia. What is the most likely cause of his condition? So he clearly has some neurologic deficits, right? There's issues in his neurologic exam. Now, let me show you what you need to learn about question taking. Like, this question itself is not that far-fetched at all, but these kinds of questions, what do? You know, either step 1 or CK. You sit down, you're looking at it. What are you going to start highlighting? Well, definitely every time I told you, highlight the first thing, right? Age and gender. Definitely need to know. None of the other symptoms. Don't ever highlight symptoms in the first sentence, because you want to hear more about this as the question goes on, right? One of the issues with highlighting symptoms here is that it could be something that the patient said, not the physician said, and the patient's going to say he has chest pain, the physician's going to say he has GERD. So you got to be careful with that. Don't highlight symptoms here. Keep it in your mind, and of course it's the first sentence, you can always read it again, but don't highlight symptoms here. His parents say that he was having difficulty moving his right arm and leg over the past 3 hours. This, you could highlight something here, but you're probably still better off not. Just leave it. You get it. There's something wrong. Physically movement. 10 hours ago. So this I care about, so I'll highlight. He tripped on a toy, fell, toothbrush in his mouth. Now I get the story. I can imagine this in my mind, so I'm still not going to highlight anything else about him tripping or falling or anything like that. He cried, but his parents did not know any oral bleeding, so still nothing to highlight here. From this sentence, I already told you that what I'm going to think is, yes, he can talk. Yes, he can eat. Right? So esophagus and trachea, larynx, they're working just fine. Then, you know, typical students would highlight things here too. They would highlight that he has ADHD and takes methylphenidate. They would highlight that his mom has, they would highlight them. So this is what they would highlight. They would highlight ADHD, methylphenidate, migraines, stroke. You know, it's very possible these are things that you'll highlight. You don't need to. It's absolutely useless. That information is not going to help you with the question. You may not know that when you're first reading the question. That's very true, right? And then you get to the end. But the fact of the matter is that, look at this sentence. He has ADHD and takes methylphenidate. The two things cancel each other out. And methylphenidate is just a stimulant that doesn't really mean much here for his case scenario, because this isn't a question about like an cerebral infarction or cerebral aneurysm or anything like that. Right, so it's irrelevant. His parents having these typical things doesn't mean much. You know, for a person to die at age 62 with a stroke, not that far-fetched. If it said his dad died of stroke on age 30, that would be definitely a red flag I'd watch out for. Right, and mom having a history of migraines, not that far-fetched. So not really things you need to highlight. Now, any exam, physical exam, neurologic exam, whatever exam they're doing, that matters. Any imaging labs, you always highlight, right? So here, neurologic exam shows all this stuff you care about, and you would highlight it. You know, you would either highlight the whole thing, right hemiplegia, right hemianesthesia, and mild motor aphasia, or just highlight this so that you know where the neurologic exam details were in the question. I like doing the little highlighting. Just highlight neurologic exam because I care about that exam, and then I'm going to look at the answer choices. Now, because of the way this kid fell in the scenario, right, this is the image you would be painting for yourself. You may not be painting the image of the artery back there, but this is the general image you're painting for yourself. The brush going straight back like that. The only possible way something could have gone wrong is that you must have injured something that was supplying the brain, because you didn't injure the brain, right? This toothbrush going down there is not going to injure any major brain related nerve, right? Nor does it penetrate through to the brain. So you look at your answer choices, you see internal carotid artery should be the safest answer choice to pick, and you just go with it. The other arteries that would be involved probably don't supply the brain, right? It's clear that something supplying his left brain, right? Because he's got right-sided symptoms. Something supplying his left brain is causing him to have neurologic deficits, right? Initial injury to the internal carotid artery can result in dissection or thrombus formation, which occurs over hours to days and can extend into the MCA or ACA, leading to symptoms. This can also be a consequence of neck strain or manipulation, right? So here's that little thrombus he's got, and this really sucks, right? Other ways, this same scenario with the same answer choice can also occur from the same answer choice can occur from a different scenario too, which is like this, right? Then maybe the kid was doing something weird and he twisted his neck, and you can see same kind of internal carotid injury from twisting his neck in a really weird way because of some kind of sports event or some kind of chiropractic manipulation that you can see all the time on YouTube and TikTok. Some of those look really weird and scary, and then you're just really wondering if that was actually healthy or safe. Most times it is, but a lot of times it's also not, and you got to be very careful with those. So that's another scenario showing you the same injury, right? So this is another question of its own, basically. And another way this answer choice could be written is C1, C2, C3 area vascular injury, right? That's another way to rephrase the answer choice. So these are some things you want to consider when you see questions like this, right? That's a typical CK type of question. Very nice question, straightforward, tells you what happened, leaves it up to you to figure out what was needed. All right, so we got the airway stuff down. Now breathing assessment: breath sounds, chest rise, oxygen saturation. Airway was everything for upper respiratory system. Breathing is about lower respiratory system, which is basically everything after your trachea, so from your lungs. If patient has unilateral breath sounds, think pneumothorax or hemothorax. And the differentiation between the two is a very simple little thing. It's based off of percussion. If you do percussion and you find dullness to percussion, that means that you're trying to play the guitar strings and you hear minimum sound. That's probably because there's liquid there, which is blood, right? So hemothorax. So anytime you have a patient with left-sided breath sounds are low, and then they say dullness to percussion on the left side, that's a hemothorax on the left side, right? At that point, you don't care about where the trachea went. They might tell you trachea deviation, but it doesn't matter when it comes to hemothorax, right? And then the other one, if you have resonance or hyperresonance, then that means you play the guitar strings and you heard loud sounds, which means there was air for sound to travel. So that's a pneumothorax, right? And with the pneumothorax, that's exactly how it's going to be. You're going to get a patient with decreased breath sounds on the left side, or it could be the right too. I'm just saying left side, and then hyperresonance on percussion. That's air now, right? So that's the one word kind of thing. Hyperresonance versus dullness on percussion. That'll help you differentiate between the two answer choices. At which point you depend less on which way did the trachea deviate. In traumatic incidents, oftentimes the trachea may not even deviate anywhere, or could deviate in weird ways based on what the trauma was. All right. It's only the tension pneumothorax we know that the trachea deviates away from the side where you have the pneumothorax, right? So that's its own little case scenario, which doesn't necessarily have to be due to trauma, but could be due to trauma too. You can then verify this with a chest x-ray only if the patient is hemodynamically stable. This is a very critical thing. As I said, don't pick chest x-ray, CT scan, or the MRI as the next best step until you first have the patient stabilized. You need to stabilize your patient before you send them away from the trauma bay to go get imaging done, right? Imagine you're sending the patient home to go get imaging done at their own little local center. So would you send an unstable patient home? No, right? So that's kind of how you want to imagine that. Insert chest tubes to expand the lung as necessary, especially in pneumothorax. If patient has unilateral breath sounds on the right after intubation, consider right main stem bronchus cannulation. Now this is another answer choice you're going to get, right, when a patient is having difficulty breathing. So remember the way your trachea was. Let's go look at a nice respiratory image to see how the trachea looks like. This one is pretty decent. So the way we know the tracheas are branching out, we know that it's really easy to send things into the right side, right? That's why most things that are eaten by mistake into the trachea, inhalation issues, like a peanut, would go straight down the right side, right? So food that comes down, in pediatric case scenarios, goes straight into the right side because it's easier as opposed to this angle, right? Now, when you're inserting a tracheostomy tube into a patient, you could theoretically push the tube too far into the right side, okay? So it's very important to understand what would happen. So I'm inserting a tube into here now, right? So the tube only went into here when it was supposed to sit right here in the carina. It was supposed to sit there in the middle and take air from both sides and bring air into both sides. Chest X-ray may show endotracheal tube below the carina. Would draw the tube above the carina to oxygenate both lungs. Now there's something specific that should happen here, right? If we're comparing this to hemothorax or pneumothorax, right? So let's say that our patient has a pneumothorax of the left lung, right? So the left lung has a pneumothorax, then there will be decreased breath sounds on the left lung. Now if I'm inserting a tracheostomy tube and it went more into the right side, it doesn't necessarily mean he's going to have decreased breath sounds on the left lung, right? It's going to be slightly lower, but not as low as it would be in a person with pneumothorax of the left lung, where there's no breathing sounds at all on the left lung, right? So the difference of whether or not this event has occurred with the tracheostomy tube is something you'll have to figure out based off of what they're describing to you in terms of sounds. Okay, don't think that the tube went into the left lung or something. Definitely not the case scenario. And don't ever think that the fact that the tube went into the right lung actually lowered breath sounds on the right lung. That doesn't happen. The tube is supposed to help you breathe, right? So if a patient has decreased breath sounds on the right lung and you're going to pick the answer choice, oh, I think you put the tube into the right lung, that's false. That doesn't make sense. If I put the tube into the right lung should have really good breathing sounds then, right? So that's something you want to keep in mind when you're making these comparisons. We're going to see a question where that was also an answer choice and a lot of people picked it, but it was the wrong answer. If patient has bilateral breath sounds and good chest rise but cannot oxygenate, then you need to intubate and mechanically ventilate, right? Because something must be wrong somewhere, but we don't need to wait and find that out right now. Don't pick the answer choice of finding that out right now and ordering a CT or something like that. Fix it first, right? Give them the ability to ventilate their alveoli. So that takes care of A, B. Now looking at C, circulation. Because if blood circulation stops, then that's another case scenario that would kill the patient before you can even do something about what trauma they've gone through. Assess for shock. Systolic blood pressure less than 90, fast and weak pulse, pallor or diaphoresis. So we know what shock generally looks like. It's a patient with low blood pressure and a high heart rate, high pulse, right? That's immediately something you consider at that moment is shock, and then you try to rule it out if necessary. 3 causes of shock in trauma are hemorrhagic shock, tension pneumothorax induced shock, or cardiac shock, which is cardiogenic shock, right? So a cardiac tamponade. So hemorrhagic shock is the most common in trauma because patients can be bleeding in places you can't see the blood occurring in, like retroperitoneally. There are only 5 places you can bleed enough to cause shock: the chest, the abdomen, the pelvis, any of your extremities, and the floor, which is basically external hemorrhage, which you would be able to see. Intracranial hemorrhage will never cause hypovolemic shock. There's a limit to how much you can bleed in the brain, and there's also limited space in there for you to bleed. Place 2, remember this is all critical information. You need to place 2 large bore IVs and bolus 2 liters of isotonic crystalloid into the patient to resuscitate their volume. Also transfuse fresh frozen plasma if more than 6 units of PRBCs are given. Okay, you need to give them fresh frozen plasma because just giving red blood cells doesn't replenish the coagulating factors and stuff like that, right? So now right here you're seeing multiple things you can get questions on. Questions I've seen include a case scenario where they explain the whole thing that happened, all this accident and whatever. The patient came in, patient was checked for ABCDs and whatnot, they were being resuscitated, only 1 IV had been placed so far, and then they describe a bunch of other shit in the question, and then they ask you what else should be done, and the answer was that you need to place another IV, right? So there needs to be 2 large bore IVs in the patient. That's very significant. Other than that, there's going to be questions where a patient might have had injury to multiple locations. So in questions you'll see they tell you there's damage in the chest, damage on the abdomen, there's a little pelvic damage, his legs seem injured, etc., etc. And then they'll ask you what you should order. So you should order imaging after the patient is stabilized and all that for each one of those 5 sections that he has trauma in. regardless of whether or not you see symptoms, because not everything is always visible, right? And this is the kind of stuff you're going to see in some of the practice questions we'll do. And if they tell you that they gave isotonic crystalloid and a bunch of red blood cells, packed red blood cells were given, if more than 6 units of packed red blood cells have been given, make sure that the next step you pick is to add fresh frozen plasma as well. Good thing that this is a multiple choice test question, right? A multiple choice kind of test. So in the answer choices, you'll see these answer choices, and it should ring a bell for you, and then you should be able to reevaluate the question to see what makes sense to do, right? Based off of what's actually happening, you go ahead and accordingly and make it happen in that way. You know, do the right thing exactly like that, the way that we're reading about it right now. Now, tension pneumothorax. There's another case scenario we just talked about. This is going to be air induced, so it's not a hemothorax. So you're going to have the pneumo induced hyperresonance or percussion. Diagnosed clinically if hypotension, tracheal deviation, low oxygen saturation overall, unilateral decreased breath sounds, hyperresonance are all present, right? The trachea should be deviating away from the side that has the pneumothorax. Then that's a tension pneumothorax, and you don't need to do anything else because one, the patient's probably not stable, so you're not going to do x-ray. Two, because you need to fix this ASAP to get the patient breathing. Oxygen saturation is always given in many of these questions. Now, if you see an oxygen saturation that's like under 95%, right, or under 90%, I would say let's keep the cutoff point 90%. If oxygen saturation is under 90%, now you're wondering what's happening. Why is his hemoglobin not getting enough oxygen? Now, under 90% isn't fatal, but it's low. It's under 90% because one lung must be good, so a lot of oxygen saturation is being fixed over there, but then it's not optimal enough to make up for both lungs, right? One lung can't make up for both lungs that easily. So that's something that should make you think there's something happening in the lungs that are not allowing oxygen to diffuse and get into hemoglobin. Needle decompress with an IV catheter right away, and then place chest tube. Do not wait for chest x-ray to intervene. As we said, they're not stable enough to go get a chest x-ray anyway, so you're not going to pick that answer choice. And you don't need it because this kind of clinical scenario you're a pro at, and you know it's exactly what's wrong with the patient, right? Here I put an image to show you the general anatomy of this area that we're talking about, right? So you can see how everything goes, and you can see how it is much easier for anything that's coming down the trachea to easily go into the right side, right? Not so much here, right? Because imagine this is your, let me make it this is your straight line right there. Anything that comes down hits this and then can easily go this way. Not so much in this angle. It just doesn't, right? It's possible, but as far as step is concerned, it doesn't happen either. So that's it. Next thing, cardiac tamponade. So tamponade we've studied many times, right? It's a pack of blood around your heart. And there were some critical things we learned about when that happens. So when that happens, you remember when you breathe in, more blood comes back to your right heart. That requires the right heart to expand. But when there's a pack of blood outside your heart can't expand. So when you breathe in, instead of expanding outwards, the interventricular septum gets pushed towards the left heart. That causes a decrease in blood pressure every time you breathe in, right? That kind of pulsus paradoxus activity you consider cardiac tamponade, right? That was a big thing right there. Now here they tell you suspect if hypotension is seen, of course, it's the shock the patient has. Muffled heart sounds because there's a lot of fluid outside the heart, so you can't hear the sounds that well. And JVD because, as I said, there's no space for the right heart to expand, right? So when they breathe in, not only is the left heart being pushed away, the interventricular septum is being pushed into the left heart, but blood is backing up the superior vena cava into the jugular veins, right? Jugular veins distension is always a sign that your right heart is not able to pump blood forward, right? Or is not able to take the volume of blood into it. Why? And in this case scenario, it's because of cardiac tamponade. Confirm with ultrasound, surgical intervention via pericardial window, pericardiocentesis, or thoracotomy. Now, ultrasounds, you don't need to send a patient somewhere to get this done, right? So ultrasound is different from ordering CT, MRI, and X-ray. In ultrasound, you can actually do on the trauma bay on bedside. You just bring the machine over, just put some gel on the patient, stick the thing onto them, and then you can see what's showing up, right? So that's a really easy and quick thing to be able to do. It just doesn't help too much in the chest and abdominal area. it really is only helpful for looking at the heart, because it doesn't really do much for you as far as seeing the lung or any bones or anything like that. So for cardiac tamponade, you may need ultrasound, but if you're like already 100% sure it's cardiac tamponade, you're pretty certain, then you can go ahead and just, you know, pick the answer of doing something about the tamponade. All right. And we'll see questions when we get there. So that takes care of A, B, and C. Now D and E. So D is just deformities. Of course, depending on how bad the trauma was, there could be some broken limbs or something, right? Assess for traumatic brain injury using the Como scale and pupillary exam. Assess for spinal cord injury by examining movement and gross sensation in extremities, right? This is always going to be necessary. Very important. After you've checked for everything else, and you can get long questions where they've already checked for everything else. They checked for airway, they checked for breathing, they checked for circulation, they stabilize those things already, and then they'll tell you what should you do now. Well, then you should check for deformities, right? Any brain injury or any kind of spinal cord injury. So now you're going to be picking the answer choices of during the MRI. And these MRI answer choices are going to be very specific. Is it MRI of the cervical spine, thoracic spine? What MRI are you ordering? So that's going to be something you'll be picking as an answer choice once you get to this point after the ABCs. And the E is just exposure. Assess visible injuries, take body temperature, log roll the patient, and perform rectal exams. So log rolling is an actual thing you do in hospital where you have to get multiple staff members. Everyone comes. You take the patient from under and you roll them over to their side. Okay, that way you could see their behind and then do a rectal exam. So picking the answer choice of perform rectal exam is something you have to do for these patients, not something just based off of whether or not there is a rectal problem. Okay, once you have gone through some really bad traumatic incident, a rectal exam is often necessary. Right, so if you see that answer choice, remember this idea. Do the log roll and then check for rectal issues. And then management, remove clothing and cover with warm blankets. Right. So these are some things that you'll have as silly questions with critical answer choices, and you're gonna have to pick these answer choices. So you definitely want to watch out for that. Don't miss the answer choice just because of the way the wording of the question was or something along those lines. Be very careful. After that, let me see. Yeah, then comes secondary survey. So primary survey was ABCDEs. I've got an image on the left here to kind of further break that down for you. Now in secondary survey, we're going to be looking at adjuncts to the survey, right? So ABCDE, really easy, right? Nothing crazy, very simple. You want to follow that order of things, take care of it, right? Here, chest x-ray, x-ray of the pelvis, FAST, right? Focused abdominal sonography for trauma, to identify sources in bleeding from the patient. We just said that there were multiple places, 5 places you could be bleeding from that you might not really notice they're bleeding. And 5 places that you could actually be bleeding from that can lead to complete bleeding out, right? That endless bleeding, and the patient can just have serosanguinous death, exsanguination. Pertinent labs should address mechanism of injury, intoxication or overdose, and medical history. Type and cross-match all patients of concern or with hemorrhage, right? Place Foley catheter to monitor urine output in hemodynamically unstable patients, to guide resuscitation in those undergoing surgery. Place orogastric tube for patients requiring mechanical ventilation. Now, all of this, is just single bullet points here, right? No, this is critical shit, right? Very important stuff. So you're gonna, first of all, if your patient in the question they told you the patient has injury in X, Y, and Z areas, chest and abdomen, you need to pick to do these things. Like do FAST if they have abdominal injury, do chest x-ray if they have chest injury, right? Trauma, they'll tell you like maybe the patient was wearing a seatbelt that caused chest injury. You need to check, right? Because in the chest, your ribs can break inward and puncture a lung, right? So that's really critical. If someone had abdominal injury, you need to check if everything's moving correctly or not. If there's perforation and you ruptured into the GIT, large colon, small intestine, whatever, then that rupture can lead to death. They can just bleed out, right? So all kinds of things. Now, this one is also really significant as choice, the urine stuff. If you ever see an answer choice that says place a Foley catheter to monitor urine output, you really need to consider that, because that answer choice should make you think, oh, whoa, hold up, we haven't done that yet? Because if we haven't done that yet, we need to do it, right? Placing the Foley catheter into the patient is part of stabilizing the patient. How are you going to fluid resuscitate a patient without monitoring how much fluid is actually going around, right? If I'm going to give someone fluid, I need to see that fluid come out in urine too, right? If I'm going to put someone on diuretics, I definitely need to see urine coming out, right? So you need to place the Foley catheter. It's part of stabilization, right? It's part of making sure the patient's doing well. And on top of that, trauma can often injure the urethra, right? So you need to make sure that there's no urethra injury, right? Pelvic injury involves urethra injury as well. We saw that when we looked at it in step 1 repro. So when we were in step 1 reproductive, I think anatomy somewhere right here. So right here we can see the male pelvis, right? And the green area is basically showing you right here, the bottom green area is showing you the flow of urine. The entire green area is showing you the way semen travels, okay? Now, you could get urethral injury based off of how bad the pelvic injury was, and that looks like this. There's 2 different variations. In really bad pelvic fractures, as they tell you here, you're going to injure this area, which is very tight. It's tight because you see how in that area the normal version is right here. The prostate and everything else is nicely holding the tube. There's no space for the tube to move around. The tube is actually held in place, connecting from the bladder on top into the penis on the bottom. If this tube moves, right, if the prostate shakes because of really bad shaking trauma from like sudden car accident where your whole body shakes, right, falling from a really high, more than 10-meter space, etc., then that movement will rip the urethra. Right, you can see this torn intermediate part of urethra, which of course can lead to excessive blood, and then the patient can die. Right, so the patient will present with shock and inability to urinate, and you'll see that right away, and you'll fix this. You'll have to fix this ASAP, right? Because you need to get the patient urinating normally. An orogastric tube, of course, right? If you have them on mechanical ventilation, how are they going to eat, right? Now, we don't really want to do TPN. Don't pick that as a choice. You never really prefer doing total parenteral nutrition on a patient, because when you do parenteral nutrition, you don't allow their gallbladder to do its job, right? And if they're hospitalized for maybe 2 to 3 days, maybe even a week, the gallbladder stasis can lead to more problems, right? They're going to get all that gall-related gallstones and all that different kinds of issues there. You don't want to do total parenteral nutrition unless that is the only way that they can actually get nutrition, right? So it'll be pretty obvious in the question, hopefully, whether or not to do that. Order radiologic studies based on the assessment of hemodynamically stable patients. So now once they're stable, what do? You need to do a head CT for any patient with head trauma, loss of consciousness, drowsiness, altered mental status, structural skull damage, or neurologic deficits. One of these things always happens, so you have to do a head CT, right? One of these things that's listed here is almost always a case scenario. If they've ruled out that none of that ever happened, then you don't need a head CT. But if any of these things happen, right, which then includes the wide thing of neurologic deficits, that last thing covers a lot. Almost every patient presents with some neurologic deficits, so then the head CT becomes mandatory, right? So it's almost common protocol to always order head CT. But again, if they ruled out completely everything and the patient doesn't have any of these things, don't pick the head CT. And then cervical spine CT is needed for all patients with neck pain, tenderness, or anyone getting a head CT. So you see how this is very like second degree kind of question. You might have a patient who you had to do a head CT for because they presented with neurologic deficits and maybe even head trauma. It was done and they told you nothing was found, okay? Then they'll be like, what's the next best step? The next step, just because you know your workflow, is to order the cervical spine CT. Anytime you order a head CT, you need to do cervical spine CT, because your brain first sends everything into the cervical spine, then it goes to the rest of your body. So if someone had head trauma or any of these other things that's listed in head CT bullet point, it could be that the patient ended up having a neck issue. Also, remember the concept of whiplash, right? When someone has really bad accidents or anything like that, the amount of movement your neck goes through is the most, right? Your neck is shaking like crazy in a very rapid 1 second moment, right? Usually a lot more than the rest of your body even shook. And the rest of your body is wide. It's a lot of things holding everything into place. There's really not much holding your neck into place besides your cervical spine. Excuse me, your cervical spine. So you need to check it. You need to look at it. let me just see where the, okay, so um I just want to look at, oh yeah, it's not that long. All right, good. We're gonna do this too. So now, after we're done with understanding all that, we're gonna look at how you deal with penetrating trauma. This section describes management of specific trauma injuries after initial evaluation using primary and secondary surveys. These considerations generally assume the ABCDEs have been done. Okay, so understand that just because someone has a neck injury doesn't mean you immediately go order CT angiography. We're first looking at, are they stable? All right, very important. This should have been like in bright red, bold, or something. Also, real quick look at some of these key facts. So up here, hemodynamic instability in the trauma setting is defined as anyone with a blood pressure under 90. When IV access is necessary but cannot be obtained after multiple attempts, place an interosseous line. I've seen this as an answer choice as well. Right? Sometimes you're not really going to be able to find IV access, especially if it's a child. Right? So interosseous line you do by placing it into a big bone. Okay, so that's something we're going to see when we look at that question. Not just any bone, but you want to pick like a bigger, longer, thicker bone wherever it's accessible in the patient. A fourth rare cause of shock in trauma is neurogenic shock, which we're going to revise when we get to the shock section. Neurogenic shock from high spinal cord injury. Disrupted sympathetic outflow decreases total peripheral resistance. Suspect after ruling out 3 main causes of shock in a patient with motor deficits. Treat with vasopressors to increase TPR. There's also another critical thing here. When we were back in GIT, we looked at Cushing and curling ulcers in the stomach, right? The Cushing ulcer was cushion your brain, right? And that was basically from a really bad brain injury. Curling ulcer is a similar concept from the same idea. A Cushing ulcer and curling ulcer, these things were ulcers that occurred in stomach, right? Peptic ulcer disease. Why does it happen? So when you get a patient with neurogenic shock, because you have decreased sympathetic outflow, parasympathetic vagus outflow goes up. When parasympathetic vagus outflow is high, you release more acid in the stomach. Now combine the fact that you're releasing more acid in the stomach with the fact that the patient is not having enough blood flow. So now you have a man or woman, you have a patient who does not have enough blood flow to their stomach, right? So the celiac artery may not be getting enough blood flow, and they have excess acid in there. You just primed them up for a really bad stomach ulcer that can perforate, right? So one of the additional things you should add here, and definitely worth putting as a note here if you haven't mastered this concept of like connecting the dots, these are some critical dots to connect. So in this patient, you also need to give them like omeprazole or something, right? H2 blocker, whatever. If you see a question where they have some antacid kind of master choice like omeprazole after a trauma incident, this is the scenario you need to consider. Is your patient going through this scenario? Because if they are, they have neurogenic shock, which you really just establish by making sure they don't have any other shock. They don't have hypovolemic shock because maybe their hemoglobin is normal. They don't have hemorrhagic shock because you checked and there's no hemorrhage anywhere. You know they don't have cardiogenic shock because cardiac output is looking okay. Then it's definitely neurogenic shock, right? It's just order of elimination once you check everything out. It's obviously not septic shock because they don't have infection in the question either. So neurogenic shock, one of the least tested things, but really critical. When we were back in step 1, I spoke about this a lot, right? You see I have this tab so I can always jump to this very easily. I always want to come back here and look at this until I master the topic, until you can talk about this without any hesitation like I just did. So right here we can see the things that happen with distributive shock and neurogenic shock. Neurogenic shock is a type of basically distributive shock. It's due to spinal cord or brain injury leading to a lack of sympathetic output. Unopposed parasympathetic vagal tone leads to a slowed down heart rate, which can be exacerbated by hypoxic disease. Now, the slowed down heart rate also makes this shock a little unique because most shock, like hemorrhagic shock and hypovolemic shock, have high pulse. Right here, it's going to be a slow pulse because you have a lot of parasympathetic rest and digest output, right? Loss of sympathetic fight or flight output. Use atropine to fix the bradycardia. If the injury is above C3, the patient will undergo immediate respiratory arrest also, which is why we always do the head CT and cervical CT. Gotta check that stuff, right? You don't want the patient to not be able to breathe. We're establishing ABCDEs first. You can see already how emergency medicine is, in my opinion, pretty fun to study, right? Because you get to see things that are actually making you feel like you're doing some doctor type stuff rather than studying what you're going to listen to on a heart sound or something. Oftentimes a lot of these don't really feel like very medical studies, especially when you're studying like microbiology. Doesn't feel like you're becoming a doctor at all, because I can't remember the last time a doctor spoke to me about any microbiology related stuff. But this feels really medicinal, so it's kind of fun memorizing and understanding the concept of what's happening to a human body as they go through really bad trauma. It's a very critical neurogenic shock concept. The last one here: a rough estimate of systolic blood pressure can be made based on palpated pulses. Palpable carotid equals 60, femoral equals 70, and radial equals 80. This I've never seen a question on, but this is like a medical skill, right? So you can get this question from like an attending physician who may have just done it or something, and they feel special, so they want to pick on you. So they'll be like, hey, how else can we figure out this person's blood pressure if they don't have time to do a blood pressure machine thing? You're gonna say, well, I'm gonna try to palpate the carotid area. If I don't feel it there, then I'll check femoral next, and then I'll check radial next. But if you don't feel a blood pulse, if you don't have a palpable carotid, they're probably about to die, and they probably are dead, right? That's how we usually check if a person is dead anyway, right? We check for breathing, and then we check for right here if there's any carotid pulsation. That's when we know they're alive. So the sign of being alive is to have carotid pulsations and at least have a blood pressure of 60. If they have that, then you move to femoral. Check if the blood is making it to their legs and their arms, right? That's what we're doing here. If it's making it everywhere just fine, then it has to be a blood pressure of 80 or above, right? Very rarely do you ever get a question where the patient's blood pressure is less than 80. And if it is, then that's a sign they must have really bad injuries somewhere that's causing blood pressures to be completely messed up. Okay. Let's take a look at this question. So it says, a previously healthy 24-year-old man is brought to the ED after a bicycle crash. He was mountain biking downhill when he struck a prominent tree root and was thrown from his bike. He tried to brace his fall with his hands, but his chest struck a large rock as he landed. So I'm going to show you what I would be highlighting as I read this question too. Right, so we got this, and then fall, and we got the chest injury, right? Chest is struck by a large rock as he landed. So that's a rock that hit his chest and he fell on it. So it hit really hard. He did not hit his head or lose consciousness, so I probably don't need to order a head CT. These are thoughts that have to go in your mind as you're reading the question. He has moderate central chest pain and severe right wrist pain. So I'm going to highlight the chest pain, the right wrist pain, because these are some things I'll have to check for the patient. Blood pressure is high. I'm going to highlight that and this. Right, so this is not shock. Right, both things are high. Oxygen saturation is good. Physical exam is significant for sternal bruising and with point tenderness. Abrasions on both palms. Abrasions make sense. Of course, he fell. He's ripped both palms. That's not something I need to highlight. And a deformed right wrist with an overlying laceration. So I already got the chest pain and right wrist. Okay, I'm not going to keep highlighting the same thing over and over. Breath sounds, heart sounds, and abdominal exam are good. They did the FAST, focus assessment with sonography for trauma. This is usually abdominal sonography. Is negative for any free intra-abdominal or pericardial fluid. So he doesn't have cardiac tamponade. He doesn't have any retroperitoneal bleeding in the abdominal area. Non-contrast CT scan of the chest reveals a hairline sternal fracture. Now stop here. Right here, because in the question they've mentioned that they're doing a non-contrast CT scan, it is safe to assume that the patient is stable. Right? Understand that too. So don't pick an answer choice where you're going to be now doing something from the ABCDEs. If they're doing a CT scan, they must have already stabilized the patient for your question. It's done. You're moving past that now. Okay. So they did the CT scan. They found fracture in the sternum, which totally makes sense. He fell full on at whatever speed onto a rock. Right. So it's like harder than any rock you could actually throw at him. He's hospitalized. Radiographs of the right wrist reveal severely displaced open fracture of the right distal radius. Great. So we see fractures in both of these places. He's hospitalized for operative irrigation, debridement, and fixation of the wrist. Throughout the day, he's noted to be persistently tachycardic, even though he is afebrile and normotensive, with normal respiration and oxygen saturation. So he's tachycardic. His heart rate is still up for some reason. Pain control is good. ECG shows sinus tachycardia with frequent premature ventricular contractions. Right, so he's got the PVCs, premature ventricular contractions. What is the best next step in his management? Well, with almost any kind of cardiac thing, what do we always do? When we needed to find a VSD, when we needed to see much regurgitation, the easiest thing to do was just to do an echo. Right? That was the answer for almost all of our cardiac things we looked at. So just do the echo. That's it. And don't fall for the answer choice. There's going to be two answer choices. They'll have transabdominal echo, transthoracic echo, right? That's really silly to fall for. Transthoracic echo is the one that's going to look at the heart, right? So you do a transthoracic echo. He sustained blunt chest trauma and has persistent tachycardia and new arrhythmia, both of which are concerning for blunt cardiac injury, right? It made sense. If the rock hit his chest and he's got this sternal hairline fracture, it's possible that the ribs that attach onto the sternum in the middle, it could have broken right there and punctured his heart, right? So we need to check that. It was all we needed to do. They already took care of the wrist. They did everything for the wrist, but notice in the question they never did anything more about the chest besides tell you that he has a hairline sternal fracture. And a sternal fracture, remember what the sternum is really there for. Besides holding the rib there, it's actually there to protect your heart. It's right in the middle, right in front of your heart. Must have had heart injury. Not a bad question at all. You can see how it's all going to be worded, and this is very medical. Feels good to see these kinds of questions, and you answer it and you're done. Right? This is a easier level question than you're going to see as we go on. Okay, so that wasn't so bad. Here we're just seeing, I left some space to add more images. You can definitely add more images or more notes here as you find questions. But this is very evidently a tension pneumothorax. Here you're getting an x-ray to see that, so it's very obvious from the x-ray. There's absolutely no lung really being shown here. It's all black, right? So something's wrong, and you can see the trachea has deviated towards the right side. So he's got a left tension pneumothorax. It's very easy, but most times if they give you the x-ray, it's a giveaway. If they don't give you the x-ray, then you have to look for hyperresonance if it's a pneumothorax, or dullness to percussion if it's a hemothorax. At which point tracheal deviation in those questions you don't really care about. You care more about the physical exam. Here they tell you always rule out urethral injury before placing a Foley catheter. We spoke about this, right? Blood at the meatus, high riding prostate, and scrotal hematoma are signs of a urethral injury. So in these patients, you need to perform a retrograde urethrogram to identify the injury, fix it, and then get them urinating. In this case of a patient, you may need to put a suprapubic catheter to go straight into the bladder over the pubic area of the skin, because the urine is not going to flow out the typical pathway in this patient. Only wounds that violate the platysma are considered true penetrating neck trauma. Other superficial wounds are treated with conservative wound care. It's not a penetrating wound if it didn't go past the platysma, right? So we are good on all that. So now we're looking at penetrating trauma. Neck. In patients with signs of arterial injury like active bleed, expanding hematoma, neurologic deficit, or hematemesis, or even hemodynamic instability, immediately secure airway and take to the operating room for exploration. This was our kid we did the first question on with the toothbrush, right? He had neurologic deficit because he had neck arterial injury, right? So that was our patient right there. Stable patients should receive CT angiography of the neck. Identified vascular injuries are treated with surgery or embolization. Patients with suspected injury to the trachea or esophagus because they can't eat or speak well, or because they have gurgling breath sounds or bubbling wound or pneumomediastinum, these guys should be evaluated via direct visualization using bronchoscopy or esophagoscopy. You need to go in and look, where's the trauma, right? Now order imaging. You need to actually go in and look. Remember, the whole GIT had the same concept there, endoscopy or colonoscopy. When you find something or you think something's in there, you go in and look. So what did we learn here? When a patient has neck injury, if they are not stable, right? In patients with signs of arterial injury or hemodynamic instability, you need to secure the A of ABCDs and then take them to the operating room. If they are stable, which was our kid with the toothbrush in his mouth, we can do a CT angiography, right? So this kid would get a CT angiography done. I don't know if they actually did explain it in the explanation, but they have it on the table here, right? CT or MRI angiography. Because he's okay, he's stable, he's actually walking and talking and all that, right? Everything's fine with him. So you need to do a CT angiography to actually see where in the blood vessels is the actual injury. And if you think that there's some kind of weird bleeding somewhere, you need to go in and look, right? Barium swallow esophagography can evaluate the esophagus as well, right? But rarely ever do we actually pick barium swallow as an answer choice unless it's a patient that's having trouble swallowing. Chest. Penetrating chest injuries are often treated during the primary survey since they often can compromise breathing or cause hemodynamic instability. The treatment of tension pneumothorax and cardiac tamponade are therefore discussed previously. We've already looked at those things already, right? Here, as they said, these are things that are treated in the primary survey already. So we've already talked about things that needed to be discussed in the primary survey. The B for breathing took care of tension pneumothorax survey, and the C for circulation took care of the cardiac stuff. So we're done with those two topics. If a previous stable chest trauma patient becomes rapidly unstable, suspect an air embolism. And that's the answer choice you're going to have to pick. There must have been some kind of air embolism somewhere that went into, and we're going to see that in this question, went into some blood vessel, and then the patient now has become unstable again. A new diastolic murmur after chest trauma suggests aortic dissection. Massive air leak into the tube thoracostomy suggests tracheobronchial injury, which means you need to do a nasotracheal thoracostomy at that patient, right? Because their tracheobronchial injury is not going to allow you to put it through the trachea. These are some things that can happen in patients who've gone really bad penetrating chest trauma. Now, once they're stable, perform chest x-rays. Remember, we're assuming ABCDEs are already done. Perform chest x-ray in any patient with penetrating chest trauma to evaluate for pneumothorax or hemothorax not found in the primary survey. Aortic disruption, diaphragmatic tear, or esophageal injury may also be evident on chest x-ray. Chest injuries between the nipples require evaluation of mediastinal structures, ortho echo for the heart, CT angiography for the aorta and its branches, bronchoscopy for the upper airway, and esophagograph or esophagogram for the esophagus. These are all things that need to come to your mind for things you need to order if the question is really focusing on the fact that the patient has injury in a certain specific area, right? Because you need to fix that as fast as you can. Treatment: insert tube thoracostomy for pneumothorax or hemothorax. Get the air out, let the lung expand. Get the blood out, let the lung expand. 1500 milliliters output initially, or 300 milliliters per hour for 3 consecutive hours from the tube thoracostomy warrants thoracotomy. Right? You need to actually do more. Aortic, diaphragmatic, esophageal, or tracheobronchial injury also warrant surgical correction. Immediate thoracotomy without transport to the OR may be indicated for patients with penetrating chest trauma and cardiac arrest. Right, really crazy scenarios. So let's take a look at these 2 points right here. So key fact: leave any impaled objects in place until the patient is taken to the OR, because if you move the thing, you might open up new place of bleeding and they're not in the OR yet, so that's going to worsen the situation. 31-year-old man is brought to the ED after being involved in a motor vehicle collision as an unrestrained passenger. He was given 3 liters of normal saline in the ambulance on the way to the hospital and has been receiving 5 liters per minute oxygen by nasal cannula. He's agitated and moves all 4 extremities spontaneously. Blood pressure is very low, but still above 80, right? So 82 over 50, heart rate is 130, so he's in shock. On exam, the pupils are symmetric and reactive to light, so CNS function is somewhat okay. The neck veins are flat and the trachea is shifted slightly to the right. Over the left chest, breath sounds are diminished and there is dullness to percussion. What is the most likely diagnosis? You see here, 20% of people still fell for tension pneumothorax just because they said that the trachea shifted to the right and the left has decreased breath sounds. But there's dullness to percussion. That's a hemothorax, right? Just a silly mistake, really silly mistake. Right? Like, this is just, yeah, it shouldn't happen. This should have been 100% of people picked hemothorax. Okay, great question, but very simple and easy question. Here we have an 85-year-old woman. So with significantly elderly patients, you really want to consider even more vulnerability to all kinds of things because their bones are more frail, especially if it's a female. Their vascular setup is much more inflamed and damaged, right? By age 85, you can imagine the blood vessels of our body are not going to be what they used to be. So 85-year-old woman is admitted to the hospital due to suspected acute pyelonephritis. On arrival, blood pressure is 100 over 80, pulse is 102, so she's in some level of shock with normal oxygen saturation. An internal jugular venous catheter is placed for fluid resuscitation and antibiotics. Okay, during the procedure, she becomes restless and has shortness of breath. Repeat blood pressure is even worse, so she's in more shock. Oxygen saturation is lower, so something's wrong with one of the lungs or something. Pupils are equal and reactive to light. The trachea is midline. There's no stridor. Breath sounds are equal and normal, so it's not the lungs. So somewhere, somehow, blood is not picking up enough oxygen. Neurological exam reveals no gross motor or sensory deficit. While being evaluated, she develops pulseless electrical activity. She's about to die. What happened? What's the most likely diagnosis? Now, pulseless electrical activity is not cardiac tamponade. In fact, I don't see how this patient could get cardiac tamponade, right? And if it was cardiac tamponade, look at what they just said. They said that, where is it? Jugular venous catheter is placed. She becomes restless. Breath sounds, neurologic. Oh, was it this question? Yeah, never mind. So if it was cardiac tamponade, right, instead of describing pulseless electrical activity, they would say that the sounds are muffled, right? The heart sounds are muffled. That would be the giveaway for cardiac tamponade. Or that blood pressure goes down every time she breathes in. That would be more indicative of cardiac tamponade. Not this presentation. How is she getting tamponade? What is causing some kind of inflammation around the heart that then led to fluid around the heart? Nothing that I can see so far, right? So then air embolism, because she did have some invasiveness. She developed rapid decompensation and cardiac arrest following a CV catheter replacement, most likely due to a venous air embolism. Right? Venous air embolism results from the introduction of air into the venous circulation. Right? A small venous air embolism is okay, but a large one can lodge into the right ventricle and cause right ventricular outflow tract obstruction, or lodge into the pulmonary arterioles and prevent blood from actually circulating well into the lungs. Patients develop sudden onset dyspnea, respiratory distress, and obstructive shock. Desk-based ventilation and VQ mismatch lead to hypoxemia. Tamponade can also cause obstructive shock, but it wouldn't cause hypoxemia with VQ mismatching, and lungs would be clear. Right? So these are probably some other answer choices about VQ mismatch, making you think of pulmonary embolism or something. But this is just an air embolism, and we just read about this here as well. Right? If a previously stable chest trauma patient becomes rapidly unstable, suspect air embolism. That's actually a different scenario on its own. This patient didn't have chest trauma. We did introduction of a trauma basically with the CV catheter, central venous catheter. So internal jugular venous catheter is placed. And anytime you put a catheter into anyone, there's a chance you might have an air embolism in there, right? And this one here is another question about the same thing, so we'll look at this too. 65-year-old man, so you can see both questions have elderly patients, is evaluated in the hospital for acute onset shortness of breath. He was originally admitted 5 days ago for peritonitis due to a perforated peptic ulcer, for which he underwent surgical repair. A large bore right internal jugular venous catheter was placed during the operation. Today he was out of bed, sitting in a chair and comfortable on room air. The internal jugular catheter was removed. Minutes after catheter removal, he develops acute onset shortness of breath and cough, because during removal of the catheter, you must have introduced an air embolism. On exam, he appears in respiratory distress, blood pressure, pulse, pulse is high, oxygen saturation low, concerning. Why? Jugular veins are distended, breath sounds are normal and equal on both sides. In addition to high flow oxygen supplementation, he should be immediately placed in which position? Very interesting concept. So right here you can see the air bubble. Right, so they're saying put your patient on the left lateral decubitus. Make them lay like this. When they lay like this, the air that you introduced into their internal jugular vein, right, that air entered the right atrium and then came here. And if they were laying on their right side, it got here and then it got stuck right there. And because the air embolism is stuck right there, you can't do anything, right? Blood can't go into the lungs now, which is why the patient is presenting the way they are. So you tell them to kind of move in such a way that the bubble will come out and then go over here and get stuck over there instead, right? This actually is very significant and a very important thing to do, right? And if you've ever had like a bubble stuck in any kind of fluid thing, if you move the fluid thing, you can see the bubble moves, right? So same thing here. You tell the patient to first kind of bend down and forward, almost upside down in a sense, and it gets the bubble to kind of come here, and then you make them lay on the right side, and it'll get the bubble to go over there. Move the bubble out of the way so that blood can enter through the pulmonary artery into the lungs. All right, very tricky kind of thing, but very fascinating as well. All right, so left lateral decubitus. 25% of people chose semi-recumbent. Recumbent thing is for patients with heart failure. It helps them, not the patient that sleeps with a lot of pillows, for example. His sudden onset respiratory distress after removal of a central venous catheter is most likely due to a venous air embolism. The venous circulation is susceptible to air embolism due to relatively low intravascular hydrostatic pressure. Venous air embolism travels to the right ventricle, where it can obstruct the right ventricular outflow tract, or it can travel further to the pulmonary arterioles and obstruct pulmonary capillary flow, at which point laying like this wouldn't help. And that would lead to VQ mismatch with hypoxemia. Obstructive shock and cardiac arrest can result. Patients with suspected venous air embolism should immediately be placed in the left lateral decubitus or left lateral Trendelenburg, where you have left lateral decubitus with head down position, which traps the venous air embolism on the lateral wall of the right ventricle, preventing right ventricular outflow tract obstruction and further embolization of the air into the pulmonary circulation. High flow oxygen or hyperbaric oxygen is also important, as it shrinks the air embolus by encouraging the absorption of nitrogen gas into the blood. Semi-recumbent position may lower the risk of venous air. Why did I put P? In intubated patients on mechanical ventilation. I'm not sure what P was for here. It might have, but P is nowhere near the letter E. So either I meant to write venous air embolism, or there's actually something else with the P. Ventilator associated pneumonia. Okay, semi-recumbent position may actually lower the risk of ventilator associated pneumonia in intubated patients on mechanical ventilation, right? Because that is actually a thing in hospitals. It happens a lot. So that's another place where you have the patient lay semi-recumbent. That's because if they're not semi-recumbent, there's a high chance of aspiration pneumonia too, and while having the mechanical ventilation. So that's your concept of understanding venous air embolisms. Both of these questions were not the way the book describes it. A patient with chest trauma. Both of these are patients you kind of sort of induce trauma in with the central venous catheter, right? So just get them to lay on their right, on their left side. Get them to lay on their left side like this. Put the right ventricle up so that the air bubble comes up, and then give them hyperbaric oxygen. And that's what you're seeing here. Right. We did the chest, abdomen. Okay. Penetrating trauma to the abdomen is defined as any object, typically gunshot or knife, that violates the peritoneum. An important step in management is determining whether peritoneal signs like guarding, rigidity, or rebound tenderness are present. These injuries are managed according to the mechanism. Gunshot wounds below the nipple, fourth intercostal space, require immediate exploratory laparotomy. Right, gunshots below the nipple in the below the fourth intercostal space, which is now the abdomen, basically, requires immediate exploratory laparotomy. You need to go in there, find the bullet, take it out, close anything that was punctured. Abdominal stab wounds warrant immediate exploratory laparotomy if the patient exhibits hemodynamic instability, peritoneal signs, or extruded bowel or omentum. If the patient does not have these indications, explore the wound and identify violation of peritoneum. If a defect is found, laparotomy is still generally indicated. So what we're seeing so far with abdominal stuff is you need to open the abdomen up, go in, and do laparotomy. If peritoneum is not violated, observe the patient for 24 hours. Perform laparotomy if the patient develops hemodynamic instability, peritoneal signs, or drops in hemoglobin, or even leukocytosis due to some infectious thing that must have been introduced. Generally speaking, though, with abdominal stuff, and you can look this up on YouTube as well, how it looks like to do this. With abdominal trauma issues, you would generally be doing laparotomy. You need to go in, find what happened, and then fix it. There's so much in the abdominal area, and then add on to the fact that this patients may be even obese, but there's like multiple layers in there, right? You have colon on top of colon with the small intestine, and then you have your large colon that kind of expands and closes in and out of each other. So you can't see anything on just imaging, right? Nor can you really fix it by just looking at it on imaging. So you need to go in. But if the patient's perfectly fine and they're stable, then of course don't pick the answer of doing laparotomy. Last thing here, extremities. Neurovascular assessment is critical. Check pulses using palpation and Doppler, motor function, and sensory function. For hard signs of vascular injury, right? Hard signs like expanding hematoma, pulsatile bleeding, or absent pulse, immediate exploration and repair. For soft signs of vascular injury, like neurologic deficit from the kid that messed up his carotid artery with the brush, or significant bleeding or weak pulse, do CT angiography. So these are the two different answer choices. So of course, the more severe, the more intense the answer choice. Extremities with multiple injuries are generally treated in the following order: fixation of broken bones, revascularization of arterial injuries, and reapproximation of injured nerves. Okay, gotta fix the bones first, because bones are the tree around which the vines, which are our arteries, wrap around. If you try fixing the arterial injury and then try fixing the bone, then while fixing the bone, you might break the artery again. So you need to fix the foundation, which is the tree, then fix the artery, which goes around it, then nerves, which also goes around and hooks onto both arteries and muscle and bone. Bone is the foundation of our body. We need to fix the bone first. It shouldn't be too hard to remember that. Right, so I have the BIN mnemonic for this, BIN, right? Bones, injuries, and nerves. The injuries reminds me of arterial. Okay, but whatever works for you should be pretty logical. If an injury separates an appendage from the body, parts should be placed in gauze moistened with saline. This was a question on UWorld. Okay, they had a question about a guy whose finger came off, and his wife or someone took the finger and brought it to the clinic. How should it be transferred to the surgical person who's going to put the finger back? It should be transferred in gauze moistened with saline. The answer choices had a lot of other weird things, like put it with ice or something like that. Those might be things that the wife did at first to bring it in, but no, that is not the correct thing, because remember, this is now a limb that's no longer attached to good circulation. If you ice it, you actually risk just over icing it and killing it, right? Frostbite. So be careful with the ice answer choices. It's just gauze moistened with saline, sealed inside a plastic bag, placed on ice to maximize tissue viability. Right? In a lot of the wrong answer choices, it was placed, just place it in the ice, or some of the answer choices are put in a plastic bag and then place it in ice. No, you need to have all of these things. This is the perfect answer choice. Looks like this. Okay, gauze moistened with saline in a plastic bag, and then place that on ice and then send it in. Right? The purpose of ice is simply here to maintain the cells alive as long as possible, but not over freeze the cells. So right there, I'm telling you, that's a specific question of its own that you don't want to mess up. It's a giveaway. Do you remember this kind of question? Contaminated wounds require early wound irrigation and tissue debridement, of course, right? Administer antibiotics and tetanus prophylaxis. Now, this is going to be one you'll have to recall and think of, right? Someone that had any kind of puncture to extremities needs to be given tetanus prophylaxis. Even if you don't know if the puncture was through metal, right? Chances are you're better safe giving the tetanus prophylaxis than not giving it. There's no harm in giving it, so just give it to them, right? Even if the question doesn't tell you that they were, punctured anywhere with metal. Long-term complications include high output heart failure caused by formation of AV fistulas. Very common scenario. If you had a patient, huge, long question, they did all this shit for the patient, fixed up everything, then all of a sudden the patient's showing up with heart failure, same, like within, same hospitalization period, you must have at some point, and it doesn't mean you did it, the trauma could have done it too, at some point, an artery and a vein must have connected because of the ripping up that happened. Now that the arteries and veins connected, you essentially have doubled the number of arteries you had and doubled the number of veins you had. That leads to very high cardiac output, which then leads to heart failure. So that's why that's why this is called high output heart failure. Okay, very unique thing, just related to an AV fistula. Usually, where fistulas form, you might feel a bruit. So they might say they feel a bruit right here in the biceps area. They might say they feel a bruit in the person's femoral area. So if you find a random bruit in a place that normally doesn't have any bruit, no place is supposed to have a bruit to begin with, you really want to consider it must have been an AV fistula, and you have to surgically correct that, okay? Because an artery and a vein connecting immediately doubles the number of arteries and veins you had, which obviously your heart can't handle, okay? So now let's wrap this up with the remainder of questions we have here, and then we're good for today. So right here, 4-year-old boy is brought to the ED with vague chest discomfort. 2 months ago, he was in a high-speed motor vehicle collision but sustained only minor injuries. He was observed in the emergency department overnight and discharged home. Medical history is otherwise unremarkable. Vitals are normal. Auscultation of the lungs showed decreased air entry into the left lower base. A chest x-ray is shown to the left. What is the best next step in his management? So they gave you this chest x-ray of this 4-year-old boy. So, the labels weren't there, but you look at the chest x-ray and, you try to see what you can find. So on the right side, everything looks fine. I can see, the curvature of the heart. Remember, this is a 4-year-old, so I'm seeing a little extra heart on the right side, as opposed to an adult. You don't really see much of the heart on the right side. I can see all the ribs and everything's okay here. On this side though, if this label wasn't here, you'd notice it even better. On this side, there's a couple weird things in here. You can kind of see that I just traced. And you're also noticing this, right? That isn't here. Okay, so something weird right here, whatever that might be. So what could have happened on this left side of the patient and didn't happen on the right side? So, well, this kid just went through a really bad car accident. Any of us, even adults that go through really bad car accidents or really bad motor vehicle injuries in general, always have really high flexing of the diaphragm and our abs. It happens in that 1 second. Our whole body flexes. Everything flexes really, really hard to try to maintain solidarity of our body so nothing can break, right? And if all your muscles flex, your bones become safe too. So that really maintains a safety. But this sudden flexing of your entire body heavily raises all pressures, right? Afterload is high, all the internal pressures between organs is high. So in this patient, a little 4-year-old boy, there must have been a rupture of the diaphragm from all that excessive pressuring. And remember, the right side is protected. You have this, you have the liver on the right side of the person, right? You don't have anything on the left side that's big and protecting it. So the answer here was to do a CT scan of the chest and abdomen. 30% of people chose chest tube placement, right? Now, it's not that this patient has a hemothorax or a pneumothorax. That's not what happened. Nowhere in the question did they say anything that would really make you think pneumothorax. And they gave you a chest x-ray that definitely does not show pneumothorax. Remember, a pneumothorax means that if it was this patient's left lung that had pneumothorax, that would mean that the lung became tiny like that, okay? And this area would all be black, like completely see-through, like this area, but even darker, okay? That is not what we're seeing, right? It was just a test of the imagery. It's surprising that 30% of people really thought this is a pneumothorax. It's not a pneumothorax. There's contents that came up. This kid got a diaphragmatic rupture with herniation of abdominal contents into the thoracic cavity. The right side is protected by the liver, so it doesn't happen on the right. The left side, not so protected. You don't have a big organ like that on the left side. Diaphragmatic rupture can occur after blunt thoracoabdominal trauma, like this car accident, due to sudden and unequal increase in thoracoabdominal pressure, resulting in tears or avulsion. The left diaphragm is more prone to injury than the right due to congenital weakness of the diaphragm's left posterolateral region and the liver's protective effects on the right side. Some patients, especially kids with traumatic diaphragmatic injury, may initially have no symptoms and can present months to years later after progressive expansion of the diaphragmatic defect. Due to the mass effect of the abdominal organs in the thorax, symptoms may be related to lung compression, and chest x-ray may show bowel loops within the thoracic cavity and mediastinal shift. Delayed diagnosis is also associated with increased risk of hernia formation and bowel strangulation, which can be fatal, right? Because some of the stuff that came through may not get enough blood supply. Surgical repair is all you have to do, and then CT scan aids in planning of the operative approach, thoracotomy versus laparotomy, right? But definitely this is not a pneumothorax, so there was no way. I was surprised to see 30% of people pick that answer choice. Also, assuming that this is CK, by now anyone doing UWorld CK should, most people do step 1 first. People should be good on this topic, so it's very surprising to see that. Here we have 23-year-old man was extricated from his vehicle following a motor vehicle collision in which he was the unrestrained driver. He was found unresponsive at the scene and intubated by paramedics. He received 2.5 liters of normal saline over 20 minutes en route to the ED. His medical history is unknown. At the ED, his blood pressure is very low, pulse is fast, so definitely in shock. He responds to strong vocal and tactile stimuli by opening his eyes. Pupils are equal and reactive to light. There are multiple bruises over the anterior chest and upper abdomen. Neck veins are flat, trachea is midline, extremities are cold, so he's definitely in some kind of hemorrhagic shock. The abdomen is mildly distended. Cardiac monitoring shows tachycardia. What is most likely to be seen in him? So now this is a great question. They gave a lot of things in the question. There's a lot of things in this question that you needed to focus on, and they want to know what you're going to see in him, which is a very vague question because you're going to see a lot of shit in him. So what's the most significant, right? So the correct answer for this patient specifically was a small left ventricular cavity volume with an ejection fraction of 75%. Why was this correct? Other people chose diastolic collapse with elevated right ventricular pressures. Now, more people should have got this answer right. This was a very easy answer choice. When they ask you a vague question like this, what are you going to see in this patient? Well, shit, I'm going to see a lot of stuff, right? There's going to be a lot of issues in this guy that went through this really bad car accident. But one thing I'm definitely going to see in him is that, you know, we can tell his heart is working. He's got a high pulse. He's got tachycardia, so his heart is pumping, but it's pumping fast. Heart rate is up, right? So if heart rate is up, it must be maintaining ejection fraction. What he's going to have, because of his issue of shock, is that he's got a loss of blood, right? So he's probably going to go into hemorrhagic shock. So although his heart is pumping, not much blood is coming out in each pump. So he's going to have a small ventricular cavity volume, but ejection fraction will be maintained. Okay, more than 55%. This patient with blunt thoracic and abdominal trauma is most likely in hypovolemic shock due to massive internal hemorrhage. Loss of intravascular volume leads to a decrease in venous return to the right atrium and a consequent decrease in cardiac output and systemic blood pressure. In an effort to maintain adequate cardiac output and organ perfusion, the sympathetic nervous system is going to get activated, and he's going to have peripheral vasoconstriction and an increase in heart rate. By doing vasoconstriction, you squeeze your blood vessels and send blood out of the blood vessels and to the organs. So that makes sense to do. That's why, you know, blood pressure isn't going to go up, but blood movement is going to go up. Remember, if you vasoconstrict in any normal individual, that will increase blood pressure. In shock, the vasoconstriction is just trying to make up for the loss of blood pressure they've already suffered, right? So blood pressure does not go up, but vascular resistance goes up in an effort to send blood out from blood vessels and into the organs that need it. The left ventricle decrease in size due to low filling volume compensates by increasing ejection fraction. These responses create the typical clinical presentation of hypovolemic shock, which includes hypotension, tachycardia, cold extremities, evidence of poor organ perfusion, and physical exam evidence of hypovolemia, such as the flat neck veins. Despite the compensatory mechanisms in hypovolemic shock, cardiac output cannot be sustained, and circulatory collapse occurs in the absence of aggressive volume resuscitation and control of volume loss. Diastolic collapse, with the other answer choice, due to elevated right ventricular filling pressures, is characteristic of cardiac tamponade. This scenario can occur in the setting of blunt thoracic trauma. However, JVD and distant heart sounds should be present, right? Diastolic collapse means that you are unable to fill your heart. If you're unable to do diastole, that means that something must be stopping your heart from expanding, which would be the balloon of blood around the heart in a tamponade. That's not what this patient has, right? And when you have tamponade, when you have diastolic collapse, when you're unable to do diastole, blood is going to back up into the jugular vein, and he doesn't have jugular venous dissension. His jugular vein is flat, right? So those are some things that help you rule out a lot of answer choices. Next thing, 27-year-old man is brought to the ED after being thrown from the back of a pickup truck at high speed. Things that happen. He received 2 liters of IV fluid in transit to the hospital. His blood pressure upon arrival is 60/40, so practically about to die. His pulse is 120. He's awake and without focal neurological signs. He has a distended, tender abdomen and stable pelvis with no deformities of the lower extremities. So something is really messed up in his abdomen, right? Because this distended, tender abdomen is peritonitis. So something's bad there. A portable chest x-ray is normal. What is the most appropriate next step in management? Well, with the abdomen, we always said if there's something wrong in the abdomen, you have to go in and look, right? So exploratory laparotomy and administration of blood products. You need to go in and see what happened. Did his small intestine rip up? Does he have bleeding of the small mesenteric artery or something? You know, you can't see any of these things just by doing simple CT angiography or whatever. There's just too much in the abdomen, from out in the front where your belly button starts to all the way to the back where your back skin is. There's like a lot of shit you pass through. Can't see it all on CT and X-ray, so gotta go in. Okay, this patient is fine besides the abdominal tenderness and of course the shock that they're in due to something happening in the abdominal area. There are only 5 places you can bleed enough to cause shock: chest, abdomen, pelvis, extremities, and external. Since he is in shock, we need to make sure he's not bleeding internally. Theoretically speaking, we'd like to stabilize him and do the ABCDEs before moving forward, but abdomen is a exception. You can't stabilize abdominal shit without first going in. So that's why you have to go in here. Okay. 53-year-old man is brought to the ED after being involved in a motor vehicle collision as an unrestrained driver. He was found unresponsive at the scene and was intubated by the paramedics. On arrival, blood pressure was 74/50, pulse was 116, so he's in shock. He's intubated, mechanically ventilated. Trachea is midline, multiple bruises over the anterior chest, so we have to check that. Breath sounds are present and equal bilaterally, and heart sounds are normal. Central venous catheter is placed for fluid resuscitation. Initial CVP is 12. After rapid infusion of 2 liters of normal saline, his CVP is 18. Blood pressure is about the same as it was. What is the most likely diagnosis, right? So now, they only told you, they actually gave you the answer. They told you that he had really bad anterior chest, right? Multiple bruises over the anterior chest. And then they told you that his breath sounds are fine, so the lung is okay, right? His heart sounds are normal, so the valves of the heart are okay. But then he's still having shock, and even after giving all this fluid, he's still in shock, right? Giving him fluid actually raised his central venous pressure, which means that all the fluid we added is backing up. So he must have had some really bad heart injury, right? Something must have happened. Remember, heart sounds being normal just means that the valves are okay, and mechanically speaking, there's no sound being created, but the heart itself doesn't mean it's okay, right? He has blunt chest trauma from a motor vehicle collision and has tachycardia and severe hypotension consistent with shock. In patients with shock, a central venous catheter is often placed to facilitate fluid administration. It also allows measurement of central venous pressure, which is the pressure in the superior vena cava where the catheter tip is located. Since superior vena cava pressure approximates right atrial pressure, central venous pressure provides an estimate of cardiac preload. The central venous pressure the central venous pressure value can help differentiate between different types of shock as depicted in the table above. In the trauma setting, shock is first assumed to be due to hypovolemia, which would cause low central venous pressure, of course. However, this patient has elevated central venous pressure. Therefore, a source of cardiogenic or obstructive shock should be thought of, right? Central venous pressure is the pressure in your central vein in the superior vena cava, in your jugular vein. So if there's a lot of fluid backing up, then it must be obstructive or cardiogenic, okay? Hypovolemic is always going to have flat neck veins and decreased central venous pressure. So that's general commonsensical stuff, but now you're being taught it, so it really should become common sense and stick to you. Blunt cardiac injury due to blunt chest trauma can lead to cardiogenic shock with acute right heart dysfunction causing elevated central venous pressure and left heart dysfunction causing refractory hypotension, or even lead to obstructive shock from cardiac tamponade. We don't know which one he has, specifically speaking, but he has one of them. Both of those case scenarios increase central venous pressure after giving fluid, especially, and they didn't have you pick between one of the 2 answer choices. Okay, you really can't differentiate between the 2 answer choices that easily anyway. Next thing, 2-part question. 45-year-old man is brought to the ED after a high-speed motor vehicle collision in which he was a restrained driver. Although the airbags deployed, which means that there was a really bad accident, His leg smashed against the front console and he had to be extricated from the vehicle. So we need to look at whichever leg that is. The emergency medical team placed him in a rigid cervical collar and transported him to the hospital on the backboard. He received IV fluids en route. Blood pressure was high, pulse is high. He's alert and oriented, but has significant leg pain for obvious reasons. Bilateral breath sounds are good, no chest tenderness, heart sounds are good, so the valves are working. The abdomen is non-distended, so no peritonitis, right? Non-tender, no pelvic tenderness. The right lower leg is grossly deformed with an exposed, broken tibia. Ouch. Capillary refill is less than 2 seconds on both feet, which is normal. Plain x-rays of the right leg show comminuted fractures of the tibia and fibula. Okay, now watch how they switch up on you. First question they ask, what additional imaging is most appropriate at this time? And this is very much the harder version of a CK question, because it comes down to your workflow and work ethics and you knowing what you need to do for your patient when they show up with whatever issue they show up with. All right, so this patient showed up with a really bad car accident where whiplash is a thing, right? And everything was okay except his right leg and the fact that they put a rigid cervical collar. So if they put a cervical collar on him, the whiplash could have done something to him, right? A lot of times patients don't feel things because they can't. They have nervous injury, neurological injury. So one of the things we need to do for this patient who has a cervical collar is CT scan of the spine. Okay. Other answer choices were CT angiography of the legs. Why? Right, that doesn't make sense. You don't need to do CT angiography of the legs. You know he's got a really bad fracture in the leg. Fix the bone, then fix the artery, then fix the nerves as necessary, right? 15% of people chose CT of the abdomen and pelvis, but he just said that his abdomen is perfectly fine, pelvis is perfectly fine. So why would we do CT of abdomen and pelvis? Right? He doesn't have injury to those areas. CT scan of the spine is necessary. His evaluation, as with any trauma patient, began with a primary survey which showed an intact airway, normal breathing, and hemodynamic stability. Adjunct imaging that follows includes portable chest and pelvic x-rays, focused abdominal sonography for trauma, and cervical spine imaging. Cervical spine imaging should be performed wherever there is a high energy mechanism of injury, such as a car accident or falling from really high. Even when a high-risk mechanism is not present, imaging may still be indicated according to clinical decision rules of Nexus low-risk criteria. Another thing you'll have to look at. We'll see it next time. Any one of the following is an indication for cervical spine imaging. So the more correct and accurate answer here is CT scan of the cervical spine. All right. So what are the things you look for? Well, neurologic deficit, spinal tenderness, altered mental status, intoxication, and distraction injury. He had a distraction injury, right? He may have some of these other things as well. We don't know for sure, but distraction injury for sure. Any injury where he wasn't ready for that, right? He has both a high energy injury and a distraction injury of his right leg fracture. Imaging should be done before urgent surgical intervention for his open fracture because he may need orotracheal intubation and neck manipulation. CT angiography of the legs is indicated if there are signs of vascular injury, but his capillary refill is normal in both feet, so his pulses are okay. CT of his chest and abdomen are also unnecessary because those areas are fine. So then in part 2 they tell you the correct answer, so you feel like shit if you chose the wrong thing in the first part, and they ask you another question which you hopefully will get right. CT of his cervical spine shows minimally displaced fracture of the right C5 lamina with subluxation of the right C5-C6 facet joint. On further exam, he has weakness of right wrist extension and loss of sensation on the right thumb. What additional imaging should be obtained? Well, we did the CT of the spine. You look for the other answer choices, and because of the way he has the CT of the cervical spine showing injury, you need to check the rest of the spine. Okay, so CT of the thoracic and lumbar spine was the answer choice, which again only 40% of people picked. Anytime there is a single vertebral fracture after blunt trauma, it is an indication to image the entire spine because there could be another vertebral fracture somewhere else, possibility of 20%. So just another thing you learn from questions that the book didn't really talk about. All right. So that's basically it. That's your general understanding of those topics. In our next session, we'll move on to blunt and deceleration trauma, some of the things we just looked at right now.